for older adults. Dr. Chambers also remains active in research with the appointment with the Briere Research Institute, as well as with the University of Ottawa, McMaster University, York University, and the Institute of Clinical Evaluation Sciences. His research and consultation interests focus on epidemiology and program evaluation issues related to healthy aging, public health, and post-professional education. In 2012, he received a Canadian Institute of Health Research, Canadian Medical Association Journal, Top Achievement in Health Research Award in the program of Research on the Cardiovascular Health Awareness Program. Welcome, Dr. Chambers.
Good afternoon. So I've been asked to speak on theories of organizational performance and approaches to promoting organizational learning, adding value and innovation in seniors' care. When we talked about the session this afternoon, we thought it would be better for my more dry presentation to come last rather than these first very exciting data-driven presentations. So I wanted to talk about 5 things very briefly. Oh, sorry. I want to talk about 5 things very briefly. The determinants of quality and quality improvement in long-term care facilities, determinants and outcomes of organizational readiness for change, construct validity and key performance indicators, and quality assurance cycle. So I'll try to give examples of each of these. That's what I'm planning to do, so see what you think. Let's see, how do I do this? Got to get coordinated here. So the determinants of quality and quality improvement. I looked at the literature, and it was interesting. I think it's 7 years ago when we started these sessions. There was a lot of debate about is there any research in long-term care, and this is kind of a summary of 5 things that are determinants of quality and quality improvement. Leadership, and there are a number of studies now that are quite recent, as you can see, collecting the kind of data we heard earlier to demonstrate the importance of leadership. Supervisory support, more studies, communication, staff, and consumer engagement. I don't know, something happened here. I don't know. Anyway, my assistant didn't do it right. Anyway, so I'll have to get that sorted out. The next talk is about organizational readiness, and this is based on this paper that my colleagues tell me is highly referenced. If you look on the website for the Implementation Science Journal, you see this comes up an awful lot. And the authors point out that there's a big difference between readiness and capacity. Readiness is a different concept. And so issues around strategies to look at the discrepancy between current and desired performance levels, fomenting dissatisfaction with the status quo, creating an appetite for vision of the future and changing the state of affairs, and fostering confidence that this future state can be reached. And so this author also points out that we need more research on efforts to advance measurement in this area, produce cumulative knowledge in this area, and inform practice. So I'll do the next slide. This is his model, and I'll just mention a few of the things that are in here. One of the things that he points out is that it requires improving healthcare delivery entails collective behavior change in the form, collective behavior change, like we heard in these 2 presentations, the whole organization or the whole system in the form of system redesign for multiple simultaneous changes in staffing, workflow, decision-making, communication, and reward systems. So again, organizational readiness is really the psychological and behavioral readiness to take action. And as we've heard in these other 2 presentations, it's very much a team sport. Both speakers pointed out that it can't be done by, I think you said the inter-RI coordinator in the home. Some of the other things in here are the concept of change valence at the top there. And basically this is, do the organization members value the specific impending change? So if people don't really want to get there, it's not going to happen. And then change efficacy, which is the organizational readiness for change is a combination of change commitment then and change efficacy. And change efficacy has to do with the people's assessment in the organization of what's required to do the change, their knowledge of task demands, resource availability required for the change, and situational factors such as the time to implement the change and the political environment. And then finally, just speak about implementation effectiveness, like there's change-related effort, initiation, persistence, cooperative behavior. We heard that in this last presentation. It took you 3 or 4 years to get that response rate up to a very respectable level. But implementation effectiveness, again, is differentiated in this article between implementation and innovation effectiveness. And basically, they argue that innovation effectiveness would be measured by consistency and quality of organizational members initiating an early use of new ideas, new programs, new processes, new practices, and new technology. And we need, as we've heard at these 2 previous speakers, organizational leaders, innovative champions, and other change agents to make these sort of things happen. So what I wanted to speak about for a minute is the PATH project, Partners Advancing Transitions in Care. And I'm on the board of the Change Foundation, which is related to the Ontario Hospital Association, but the Change Foundation has decided to do a case study, if you want to call it that, in Northumberland area of Ontario. And I'm not going to go into a lot of detail about this, but basically the idea was could we bring the whole community into a focus on patient-centered care with all the key actors? And you see that we have the hospital, 12 long-term care, 12 other health organizations, including a long-term care home, social care, and patient advocacy organizations. And we had a competition throughout the province, and 28 organizations expressed interest, and it got down to the last 5, and this one was chosen because we didn't have enough resources to do the whole province. The good news is that the HealthLinks program has been using this project extensively in its conceptualization of HealthLinks. So what I thought you'd be interested in this afternoon is the change kinds of activities that have been developed through this developmental program evaluation approach, which includes building awareness, changing values, and planning ahead through discussion by seniors and caregivers about this, coming up with My Health Story to help people understand their lived history, patient-centered provider model where it's a combination of the care provider and the family and other key people in the process, transition coaching and advocating so that people don't get lost in the system. And then, as we heard in the first presentation this morning, discussion about different funding models that would facilitate better transitions. So that took a long time to get that thing going, and many of these kinds of issues had to be brought into that, and I don't have time this afternoon to go into that, but that's another talk. The second example is the Alzheimer Society of Canada's project, Culture Change Towards Patient-Centered Care. And this arose out of a concern for care for people with dementia in the country, and they came to the conclusion that maybe if we knew about organizations, long-term care facilities that seem to get it right with dementia care, we should go and look at those and document what's happening. And so, to make a long story short, 6 organizations have been identified, and they were studied extensively. And out of that process, they've come up, you can go on the website for the Alzheimer's Society of Canada, but you'll see person-centered engagement, families, care, processes, environment, activity and recreation, leadership, and staffing, without going into all the detail because you'll be able to look at the slides that later, or you can go on the website. But those were the things that came out that rose to the top in that review of the 6 facilities. That these were primarily people involved with Accreditation Canada that identified these homes across the country. They were surveyors, and so that's how we got that list of 6. Again, we see a lot of this is because we had some people in the industry, as we say this afternoon, who were committed to finding who are the people ready for change. The next thing that I think is really important that we haven't heard too much today in the program is the importance of long-term care homes, recognizing that they are part of the community, and how do you network with the community. And so I just wanted to alert you to, there is some theory about networking by organizations, and we think about the network structure, its strength, its density, its centrality, whether there are cliques and how you work with them, and clique overlap. But I won't go into those because that's another talk too. But this is an example that I wanted to emphasize, and that's because I'm a researcher and interested in the connection between research and service and the rest of the community. This is the way we conceptualized what we called here the Community-Based Geriatric and Rehabilitation Services Academic Network. And you'll see that there are three dotted lines here going around the three kinds of activities. There's the Research Institute activity, where we have four different types of people: Research Institute scientists, clinical scientists, early researchers, and the researcher. And then as the researcher is the thing that drives that organization, how do we make them productive? And then we have the patient or resident in the service delivery. We have professional caregivers, service organization providers, and families and relatives and friends. And there's another circle there. And then we have the university college situation where the learner is the center. That's mainly why we have universities and colleges, where we have faculty member researchers, education program directors, other learners, and faculty member clinical educators. And so what we did was to, in thinking this through, we said, well, where are the people ready to change to make this a better system provincially? What we also argue is that if you're in a long-term care home, you probably have most of these resources down the street in your home too, and how are you connecting with them? But what we did was, with the Council of Ontario College, what's it called? The Council of Universities Ontario, the Colleges Ontario, the two long-term care associations, a number of university centers, we all got together as a group, probably led by the Council of Ontario Universities, and we got the government's attention, and that led to setting up these learning, research, and innovation centers. So I encourage you downstairs, or wherever it is here from here, I guess it's out there, you can see some of the booths about these centers, the three of them. And again, we have to value this because it's just been started. It's been going actually almost for 3 years, and we got 2 more years of funding. And many of us think this is a really important model that we actually looked at other countries too, and we brought people from other countries to tell us what they were doing to do this, including Norway. And this is the kind of things they do, their goals, covering research, knowledge development. They have developed a number of interesting tools. Just mention one, for example, the Schlegel Villages people have a course on leadership for all levels of staff. So that's a really exciting organizational change initiative for the province. So again, we'd want to look at implementation effectiveness in that one, like how consistent, like the sustainability issue, and also the quality of that. But I'd encourage you to keep your eyes and ears open for that sort of thing. Then this other thing that was mentioned a number of times this afternoon, if you can't measure it, you can't change it. And that was the main theme of these two talks earlier this afternoon. And I just wanted to talk a bit about measurement issues. So one of them is when we think about organizations, these people, Kaplan and others, have talked about that they're really helpful in helping us understand. We heard about a scorecard. And just for our interest, I thought it would be neat to talk about 3 types of capital that they talk about. Capital is a term that's used a lot by researchers these days, but also in management science. So human capital, the skills, talent, and knowledge that an organization employees possess, information capital, and organization capital. And what's interesting here is that how would you measure these things? The organization's databases for information and the organization's culture and leadership, et cetera. So what they argue is those are 3 sort of important entities that, if you want to say long-term care homes, should have capital in those 3 areas. So I've given you some examples here of how you could operationalize some of those types of capital. Walter Woodchus has been mentioned 2 or 3 times this afternoon, and he did this with a group of us, this study of determinants of quality staff perceptions of their work environment. Information capital, you could look at the number of homes that have already implemented the minimum data set. And organizational capital, the idea is, for example, of the percentage of staff who can identify the organization's strategic directions. So I just put up these main areas that they suggest. There's an attribute, a strategic measure, and the target and the actual. And that's what we when we talk about a scorecard, we usually think about those 3 things. What's the attribute, what's the strategic measure, and what's the target? I'll just do the culture one. Strategic objective is foster awareness and internalization of the mission, vision, and moral values needed to execute the strategy. The strategic measures are 2 in this case, customer-focused, I should say. So we heard that earlier about a consumer survey and percentage who understand the organization's mission, and other core values, the employee change readiness survey. And then you can have the target and the percent that get it. So he gives examples of leadership, also, and of alignment, and of teamwork. And so, for example, the target here was 5, and the organization got a 6.1. The next thing around measurement is the term construct validity of measures and indicators. So a measure or indicator is truly reflecting the construct or attribute when one is intending to measure according to our experiential knowledge about the construct and theories about what the construct constitutes. What constitutes the construct? So we heard that in both presentations this afternoon. Both speakers talked about the theory of what satisfaction is, the theory about what are important indicators, but they also went to the staff, they went to the other members of the organization to find out, well, have we got it right? Is it truly valid what we're doing? And we also heard in the last presentation about the importance of correlation, like to be able to determine whether the measure A is they're going in the same direction as measure B, and how do we sort that out? And then it should be consistent across all indicators and different measures. Sorry. And then I just thought I'd put up the reporting of public reporting for long-term care. So their 5 constructs or attributes are effective, accessible, safe, appropriately resourced, and focused on the population. And so they talk about an attribute, a health topic, an indicator, and provincial results. So this is an example of a scorecard for the whole province. And this is what it looks like. I just pulled this off the website, but I thought I'd put it up here. So for example, the attribute is accessible, and the health topic measure is wait times. If the attribute's effectiveness, how are they doing on incontinence or activity of daily living, on pain, on emergency department visits. If it's safety, what are the falls rates? What are the pressure ulcer rates? If it's safety, what's the medication safety? Appropriately resourced, human resources, and focused on population health infections. So what they say in Health Quality Ontario is, what does the indicator show? Why is this important to measure? And ideas for improvement, like we heard in the previous presentations. My last slide is what we used to call the quality assurance cycle is now called the knowledge translation and exchange cycle. But basically we heard that as well. When you find a deficiency, you have some standards, you find the deficiency, you introduce some new intervention, and you see if it's improved things. And we heard both of those things happen in these previous 2 presentations. So just to end with Don Berwick, who is kind of the guru in this area, he talks about culture has evidence for breakfast, soon is not time, and some is not a number. So if you don't understand those things, I'd have to give the talk again. So thank you very much.
Thank you, Dr. Chambers.